you okay? Are you ready? Yeah. So now I invite, where is the talk? Yeah, to talk about point management of eyelid tumors. She's from LVPI Vishakhapatnam, Vijayawada, sorry. Neha.
Good afternoon, everyone. So, in the next few minutes, I will be taking you through 10 key points in management of eyelid tumors. So, when you see these two patients in the clinic, are they same? Absolutely not. When you evert the eyelid, you see that for the patient on your right, there is no posterior lamellar involvement, whereas for the patient on your left, there is posterior lamellar involvement. So, whenever you see a case of eyelid nodule, it is imperative that you do an eversion of the eyelid and see for the posterior lamella. Also, you need to look at all the danger signs of eyelid malignancy. Like if you see this particular patient has a yellowish irregular eyelid nodule, distorted eyelid contour, effacement of the meibomian gland orifices, loss of lashes, surface telangiectasia, surface ulceration, crusting, and on eversion a bilamellar involvement, which are all telltale signs of eyelid malignancy. So this was a case of sebaceous gland carcinoma. So there are other benign lesions as well, wherever this the danger signs are not there, like squamous papilloma nevus or a molluscum contagiosum or a epidermoid cyst. So for them we just do a in toto excision without any margin. Whereas when we come across the red flag sign and we flag it as a possible eyelid malignancy, we perform the excision with wide margin. We take 4 millimeter of normal eyelid on all sides. We also do a margin clearance and then only perform eyelid reconstruction. So I will come to that, what I mean by eyelid margin clearance. So when many a times, like in this particular patient, as you can see, the posterior lamellar involvement is more, and we have to do a differential excision. That means the 4 millimeter margin we take from the involved area. So that is more in the posterior lamella compared to the anterior lamella for this particular patient. So intraoperative margin control, these were videos which are not playing, my apologies for that. So intraoperative margin control, we send margins for frozen section biopsy. Like in the West, the Mohs micrographic surgery is also there. We don't have that at our disposal. So once the pathologist says that the margins are negative, then only we go ahead and do a reconstruction. Whenever, like for many facilities, frozen section won't be available, we can just wait for the fixed sections, the report to come, and then only we should go ahead and do the eyelid reconstruction. Moving on to pagetoid spread or the intraepithelial spread in sebaceous gland carcinoma, we know that it can happen in 16 to 80% of cases. So clinically, we can predict pagetoid spread by looking at these features: diffuse conjunctival congestion, diffuse thickening of eyelid, loss of meibomian gland architecture, loss of eyelashes, surface telangiectasia. Any of these away from the main tumor nodule, we need to think about pagetoid spread. But this particular paper from our institute talks about, like you can see that with the presence of pagetoid spread, the globe salvage rate comes down drastically, and the metastasis and 5-year death rates are very high. And we found out that 10% of cases of pagetoid spread were missed if we just go by the clinical diagnosis. So based on this, uh, we advocate that map biopsy should be performed in all cases of periocular SGC. So multimodal treatment for advanced tumor, like earlier for extensive sebaceous gland carcinomas, the only thing in our armamentarium was exenteration, but now we have a fairly established chemotherapy regimen with cisplatin and 5-fluorouracil. We give 6 cycles of this neoadjuvant chemotherapy. We bring down the size of the tumor, and then we perform conservative surgery for extensive SGCs. So it is also very important to look for regional lymph nodes, to palpate for the lymph node in the clinic in a case of eyelid tumor, and whenever it is there, go ahead and perform a FNSE, and if that is there is spread, we need to go ahead and do a radical neck dissection. So subclinical detection at the stage of micrometastasis of the lymph node is possible by sentinel lymph node biopsy, which is there in very few centers in India, and that would improve the overall survival by timely intervention. The post-operative protocol is of extreme importance in a case of eyelid tumor. So only a wide excision of the tumor doesn't suffice. We need to post-operatively, we need to look into the histopathology. Are there any histopathological risk factors, perineal invasion, or vascular emboli, which many groups advocate giving EBRT for them. There can be a fixed frozen mismatch, 2 to 10% reported in literature. That is, that frozen section was negative, but now on the report of the fixed section you get a positivity. So whenever there is margin positivity, we need to see whether it is a lamellar positivity or a full thickness positivity. If it is just lamellar, cryotherapy will help. For a full thickness positivity, we need to give EBRT. MAP biopsy positive, also we need to treat, like topical MMC, cryotherapy, exenteration are the options. And as I earlier said, regional lymph node metastasis needs to be treated. So we also need to know where not to excise, like while excision is the standard of care, there are few exceptions, like this is a clencher, a rapidly progressive vascular eyelid mass in a HIV and hepatitis B seropositive patient. It was excision biopsy was tried elsewhere. There was bleeding, so the patient was referred to us. Just on starting heart therapy, the mass came down. So spontaneous resolution is possible on improving systemic immune status in Kapoor sarcoma. So again, this is a patient with multiple basal cell carcinoma, a typical case of Gall-in-Gall's cancer predisposition syndrome. So again, we need to understand that surgery or radiotherapy has a risk of induction of basal cell carcinoma in these patients. So there are multiple other associated developmental defects which are possible in this patient. So multi-system evaluation is important. To my last point, targeted therapy like imiquimod, we use, this is a patient of xeroderma pigmentosum with multiple squamous cell carcinoma. So we used imiquimod for 2 months with the lesions coming down. So imiquimod is a good option and very easily available for multiple superficial squamous cell carcinoma or basal cell carcinoma. So for medical management, a drug which has been described in literature but we don't have it available in India is vismodegib, and it is used for unresectable or metastatic basal cell carcinoma, but it is extremely expensive and we need to give lifelong, where as soon as we stop the drug there is recurrence. So to conclude, differentiate benign versus malignant, performing toto excision for benign lesions and wide excision with margin for malignant lesion. Best to perform MAP biopsy for all periocular SGCs. Chemoreduction helps in performing conservative surgery for extensive SGCs. Screen for regional lymph node metastasis. Protocol based management following excision is very important in eyelid tumors. Know when not to excise. Targeted therapy, new hope for locally advanced and metastatic basal cell carcinoma. Thank you, everyone.
Thank you, Anasua. Very nice presentation with all the pictures, very nice pictures and nicely depicted. Anybody having any discussion or doubts or anything? The audience?
I think it really needs to be reiterated again and again to the non-oculoplastic surgeons and lay people not to meddle with a suspicious looking lesion unless they are very sure that it is not malignancy, because those are the cases which become very bad and not much, in spite of all the best therapies, sometimes the patient may have to lose the eye at best or life at worst. Sometimes they do spread. That's really necessary. What all the points you brought out are very important for non-oculoplastic people and residents to learn and take to heart really. Thank you for a comprehensive presentation.